Well, good afternoon, everyone. My name is Nora Spencer-Lovell, and I'd like to welcome you to today's CDC Partner Update call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance, and to answer questions submitted by participants. On today's call, we'll discuss updates related to the new Johnson & Johnson's Janssen vaccine and highlights regarding the new federal vaccination programs. First, we'll hear from one of our science officers on CDC's COVID-19 emergency response, who will describe where we are with the response and give us insight into recent scientific findings. Then we will hear from the Chief Medical Officer of CDC's COVID-19 Vaccine Task Force, who will share information on the recent authorization of the J&J Janssen vaccine. Afterwards, our speakers will answer questions we received over last week via email. I encourage you to stay until the end because there's a lot of good news to share. If you experience technical difficulties or otherwise would like to review today's call, you can find the recording on cdc.gov or on YouTube in 8 to 10 days. All of our past partner calls can be found there, so please take time to review and share prior recordings. If this is your first webinar with us, welcome. These calls generally occur every Monday from 3 p.m. Eastern Standard Time, and you can see the link on the slide to subscribe and receive future call invitations. Please note this call is not intended for media, although we welcome you. Should you be a reporter and have questions, we invite you to reach out to media@cdc.gov. Also, today we will have 2 short polls, one now and one at the end of the presentations, to get feedback about the effectiveness of these calls. Please answer the poll now as we get started, and then again before we start the Q&A section. These calls are designed to share the latest science, guidance, and resources from CDC. CDC has issued over 2,000 resources and guidance materials for individuals, businesses, and the public on our website, cdc.gov. Here are some highlights on just a few of our recent web editions. First, we'd like to call your attention to a recent addition to the CDC's COVID-19 webpage outlining COVID-19 vaccine monitoring for systems for pregnant people. This webpage offers links to several online resources and materials for persons to learn more about COVID-19 pregnancy, breastfeeding, and caring for newborns, as well as vaccination considerations for people who are pregnant or breastfeeding. On a similar note, the CDC has been continuously updating the vSafe webpage with new information on how to participate in vSafe, troubleshooting assistance, and other related questions related to the smartphone-based tool designed to report side effects after getting the COVID-19 vaccine directly to CDC. Thirdly, the CDC has published a breakdown of how they are making COVID-19 vaccine recommendations, including their partnerships with the Advisory Committee on Immunization Practices. This release offered highlights on what ethical principles and foundational frameworks were used to navigate public discussions and guide their decision-making process. Lastly, we wanted to announce that CDC has included updated information on their guidance for childcare programs that remain open, with information about additional options for screening children upon entry to ensure that children who have a fever or other signs of illness are not admitted to the facility, as well as additional options when PPE is in short supply. And I think we can take the poll off of the screen. Thank you so much, Control Tower. Today, I'm so pleased to be joined by 2 CDC experts. Dr. Cynthia Ogden is a science officer serving in support of the Chief Medical Officer on the CDC COVID-19 emergency response. And Dr. Amanda Cohn, Chief Medical Officer on the CDC COVID-19 Vaccine Task Force and Executive Secretary for the Advisory Committee on Immunization Practices, or ACIP, is here. Now, I'm going to turn it over to Dr. Ogden for some general updates.
Thank you, Nora, and welcome everyone joining us today. My name is Cynthia Ogden, Dr. Cynthia Ogden. As mentioned, I'm a science officer serving in support of the Chief Medical Officer for the response. Today, I'd like to provide a brief update on the response and review some of the latest scientific developments. First, a situational update. Just waiting for the slide. You can see from the slide that national COVID-19 cases and deaths have both decreased slightly over the past week as compared to the previous week. As of March 5th, the 7-day average in cases decreased by 5.7% over the previous 7-day average. The 7-day average in deaths decreased by 6.7% as well over the previous 7-day average. These slight decreases in cases and deaths follow a 4-week downward trend of reported COVID-19 cases. These stats provide us with very valuable information. When these percentages are decreasing, this tells us that mitigation efforts are working. When case counts increase, this tells us that we need to step up mitigation efforts to slow the spread of COVID-19. As of March 4th, 82.6 million vaccine doses have been administered in the United States. About 54 million people, or about 16% of the population, have received at least one COVID vaccine dose. That is 32 million doses more than last week. It's also important to note that there's continued evidence that some racial and ethnic minority groups, particularly Black or African American, Hispanic or Latino, and American Indian or Alaska Native people are disproportionately affected by COVID-19. Inequities in the social determinants of health, such as poverty, access to culturally appropriate information, working conditions, and quality healthcare, influence a wide range of health and quality of life outcomes and risks. We encourage you to visit CDC's data tracker and the new weekly review for the latest stats and key indicators for the pandemic. So, new this week, I want to share some of what we've learned from a couple of reports, or a few reports, actually 3 reports released in CDC's Morbidity and Mortality Weekly Report, or MMWR. In the interest of time, I will only briefly touch on the high points of these reports. I encourage you to visit cdc.gov to read the full reports. First, we want to highlight an MMWR released on the association of state-issued mask mandates and allowing on-premises restaurant dining with county-level COVID-19 case and death growth rates. The new CDC report finds that state-issued mask requirements and prohibiting on-site restaurant dining may reduce community spread of COVID-19. The report found that mask requirements were associated with significant decreases in daily COVID-19 case and death growth rates, while allowing any on-premises dining in restaurants was associated with increased COVID-19 case and death growth rates. Findings from the new report suggest that universal and proper mask use can reduce the spread of COVID-19, contributing to reductions in case and death growth rates. The report also showed that allowing restaurants to conduct any on-premises dining was associated with increases in COVID-19 case and death growth rates. Secondly, we'd like to share an MMWR on SARS-CoV-2 infection risk among active duty military members deployed to a field hospital. In April 2020, U.S. military personnel were deployed to a New York City field hospital to care for COVID-19 patients. A robust infection control plan was implemented and enforced. Among 336 soldiers participating in an infection risk study, the overall infection rate was 1.7%. The rate among those involved in direct patient care was 0.9%. This study of active duty military personnel deployed to care for COVID-19 patients demonstrates that a low rate of SARS-CoV-2 infection among healthcare personnel in a field hospital is achievable when appropriate resources are coupled with robust infection control measures. These findings underscore the importance of adequate personal protective equipment, or PPE, use and rigorous infection control plans for the protection of healthcare personnel, especially in a field hospital that lacks the standard physical barriers and infrastructure of a traditional healthcare setting. And the last MMWR we'd like to share is the Advisory Committee on Immunization Practices, or ACIP's interim recommendation for the use of the Janssen COVID-19 vaccine. On February 28, 2021, after a transparent and evidence-based review of all available data, the ACIP issued an interim recommendation for use of the Janssen COVID-19 vaccine in persons 18 and older for the prevention of COVID-19. The report highlighted that the Janssen COVID-19 vaccine has high efficacy against COVID-19 associated hospitalization and death. Persons may receive any ACIP recommended COVID-19 vaccine and are encouraged to receive the earliest vaccine available to them. use of all EUA or emergency excuse me, or emergency use authorized COVID-19 vaccines is critical to controlling the pandemic. With that, it is now my pleasure to hand the call over to Dr. Amanda Cohn.
Thank you, Dr. Ogden. As mentioned earlier, my name is Dr. Amanda Cohn. I'm the Chief Medical Officer of the CDC COVID-19 Vaccine Task Force and the Executive Secretary for the Advisory Committee on Immunization Practices. Next slide. Dr. Ogden already shared the total number of individuals and vaccines that have been distributed. Overall, we've had a total of 57 million people have received one or more doses of vaccine, and 29 million, nearly 30 million people are completely vaccinated. That puts us at about 17.3% of the population, and 22.5% of the population over 18 years, equal to or greater than 18 years of age, have initiated vaccination. All of this data is available for review, and we continue to put up more data on COVID Tracker. Next slide. This is a slide also from COVID Tracker that shows the daily count of total doses administered and reported to the CDC by date administered. What you can see in the dark blue lines at the end, we do takes about a week to get doses in from last week, so we are not fully complete with our reporting for this week. But what you can see from the week before, for example, is that we are consistently vaccinating over 2 million people a day, and we surpassed 2.6 million people the week before last, and we anticipate that the numbers from last week will also increase to nearly those numbers. What you can also see here is the week of the winter storms that did impact vaccine distribution and administration, as seen in the data here. Next slide. So to summarize, we've had over 87 million doses administered. We are still working in a setting of constrained COVID-19 vaccine supply. We continue to rely on large vaccination centers, public health vaccination centers, as well as pharmacies for most of our distribution. We have not yet transitioned to primary care providers and more of our typical flu vaccination distribution administration pathways. But we do have more jurisdictions that are in phase 1B and expanding into phase 1C. Estimated doses by the end of March 2021 is that Pfizer will have over 20 million doses delivered by the end of this month, and we've already had over 44 administered. Moderna will have over 100 million doses, and the new J&J and Janssen vaccine will have about 20 million doses. So over the next several weeks, we will likely see constrained supply. But then as demand goes down, as more of the population is vaccinated and we have increased doses being delivered each week, we anticipate at the end of March, beginning of April, we're really going to be shifting to more expansive vaccination and potentially able to send and distribute vaccine to more vaccine administrators. Next slide. So I'm going to briefly touch on the J&J Janssen vaccine. Next slide. The Janssen vaccine is authorized for individuals 18 years of age and older. ACIP states no preference for any of the 3 authorized vaccines, and we recommend that individuals receive any vaccine that's the earliest, that is available to them the earliest, although there can be individual options and choices for individuals. It's important to understand that the results of the Janssen phase 3 trials should not be compared with the mRNA vaccines, both because they were this vaccine was studied using different calendar time, different geography, different circulating variants, different background incidents, and also different definitions of cases, different definitions of adverse events, and different background rates of underlying illness. All three vaccines show strong protection against severe COVID-19. The Janssen vaccine was 93% effective against hospitalizations, and there were no COVID-associated deaths in the vaccinated individuals versus C7 deaths in placebo, COVID deaths in placebo recipients. And so while the overall point estimate of the Janssen vaccine appears to be lower than the overall point estimate of the mRNA vaccines, the most important thing, and really what we want these vaccines to do, is protect against hospitalization and death, which all three of these vaccines do to a very high degree. Next slide. So we now have 3 vaccines that have received EUAs. To remind everyone, the Pfizer BioNTech vaccine is 2 doses given at least 21 days apart. The Moderna vaccine is 2 doses given at least 28 days apart. The great thing about the Janssen vaccine is that it is a single dose. Additionally, the storage and handling and transport of the J&J vaccine is easier and does not require being frozen for as long as the Moderna and the Pfizer products do. All 3 vaccines were tested in tens of thousands of individuals from diverse backgrounds, including older adults and communities of color, and all 3 vaccines are safe and protected and effective. We do not know how long protection from any of these vaccines might last. And while there's a lot of evidence indicating that these vaccines will reduce transmission, we are still, that data is still coming in, and we still have to monitor closely the impact of these vaccines on transmission of COVID-19 and asymptomatic carriage. Next slide. Safety of COVID-19 vaccines is a top priority. The COVID vaccines are being held to the same safety standards as all vaccines. Importantly, none of these vaccines are live vaccines. The Janssen vaccine is a viral vector vaccine, but the adenovirus that is used, for which the vector that contains the spike protein is in, the adenovirus is unable to replicate. So this is a non-replicating, non-live vaccine. Before authorization, FDA carefully reviews all the safety data from the clinical trials, and ACIP also reviews all of the safety data. As hopefully many of you are aware, the FDA and CDC are closely monitoring adverse events after vaccination, including through reporting to VAERS, which is a requirement for providers who are administering vaccine, as well as through VSafe, which is the after vaccination health checker. Next slide. So the J&J Janssen vaccine has a lot of opportunities for use. Because it is a single dose vaccine that doesn't have the same types of transport requirements as the Pfizer and the Moderna vaccine. Additionally, it comes in 5-dose vials as opposed to the 6 doses that are in Pfizer and the 10 doses that are in Moderna. And additionally, it can be ordered in 100 vaccine it can be ordered 100 doses at a time, as opposed to the over 1,000 doses at a time that have to be ordered for Pfizer. Moderna is also 100 doses at a time. But some opportunities to use the J&J vaccine include at mobile and pop-up clinics, at newly established vaccine administration sites, and at sites that do not have freezer capacity, such as potentially some adult primary care health offices. Additionally, who may want to receive the J&J vaccine over the other vaccines are people who want to complete the vaccination series quickly, who don't want to return or can't return for a second dose, or mobile populations or homebound populations. However, it's important to note that equity was a major consideration both at ACIP and through the way we're distributing these vaccines. and individuals should be aware of which vaccine product they're signing up to get, and should have individual choice in which vaccine they are getting, even though vaccine choice may not be available at each individual clinic and is unlikely to be available. Next slide. I'm going to talk for a minute now about expanding access to the COVID-19 vaccines. And these are new federal vaccination programs that are meant to augment the amazing work that's happening at the jurisdictional level in getting individuals living in each state vaccinated. Next slide. So in the early phases of distribution, administration was really focused on healthcare personnel, long-term care facility residents, and in public health clinics. And so there were not as many sites that were administering vaccine. Right now, we're really in a transition phase. Vaccines are beginning to be administered to broader populations through many different administration sites, with a focus on ensuring equity and expanding access. And I anticipate, as indicated earlier, that as supply increases, we're going to see all of these different types of places with vaccine available in the near future, including pharmacies, doctors' offices, long-term care pharmacies or providers, hopefully mobile units and ability for home health care to get vaccine to homebound individuals, public health clinics and FHQCs, Indian Health Service, the Department of Defense, hospitals, including the VA system, and these mass vaccination clinics, which you have seen in most, if not all, states. Next slide. As we're transitioning into this expanded access for vaccination, we've turned on the federal retail pharmacy program. There's a total of 21 national pharmacy partners and network administrations enrolled in the retail pharmacy program. And this allows these pharmacies to be a single vaccine administrator, even though it is being spread to multiple of their locations. And these pharmacies are able to order vaccine directly, although the doses are still being, the pharmacies that are being turned on are still being done in a pro rata level, at a pro rata way. So they're being turned on in all jurisdictions and with a focus on equity. Eventually, we'll be able to provide COVID vaccines to a provider network of over 40,000 store locations. But we're not there yet. We have several thousand stores receiving vaccine now, and as supply increases, we will be moving up towards that 40,000. We're doing an incremental rollout in close coordination with the jurisdictions, and initially pharmacy partners were selected based on their ability to reach select target populations that serve socially vulnerable populations. As supply increases, additional pharmacy locations will be allocated until the entire network is activated. Next slide. Another important federal program that has been rolled out is the Health Center COVID-19 Vaccine Program. The purpose of this program, which is being done in close collaboration with HRSA, is to ensure underserved communities and those populations disproportionately affected by COVID-19 are equitably vaccinated. So in the same way that the federal program is directly allocating through pharmacies, we're also directly allocating a limited supply of vaccine to select HRSA-funded health centers. These health centers were also chosen in the initial phase to include those that serve a large volume of disproportionately affected populations, including public housing residents, migrant and seasonal agriculture workers, people with limited English proficiency, and people experiencing homelessness. Similar to the federal pharmacy retail program, we will also be expanding the number of HRSA funded health centers that will be receiving vaccine directly through HRSA as more vaccine doses become available. We do not anticipate these federal programs impacting jurisdictional allocations. We anticipate that we will have increases in supply to support the expansion of jurisdictional allocations, as well as the expansion of these federal programs. Next slide. And finally, I want to focus on the community vaccination centers that CDC and FEMA are working on together. And this is also to support jurisdictional vaccination sites to augment and expedite overall vaccination efforts. FEMA has been working closely with each state, tribe, and territory to identify COVID-related needs. They've been piloting community vaccination clinics in sites across the US based on population and data from using CDC Social Vulnerability Index. So there's currently pilot sites in California, Florida, New York, Pennsylvania, and Texas, with additional sites set to open in Illinois and North Carolina, and additional sites in Georgia and Ohio opening soon. So FEMA is providing financial, personnel, and material resources to CVCs, and this also includes supplemental vaccine allocations in communities that need additional support to ensure equitable access to vaccines. All of these large community vaccination centers have an offshoot of a mobile clinic, so they are both opening up appointments and working with community-based organizations to get the population that the clinics are meant to serve to these clinics. But additionally, for some very hard to reach populations, they're taking doses each day and going into the communities, working closely with community-based and faith-based organizations. These vaccination centers, the largest ones, are able to vaccinate up to 6,000 people a day. Next slide. So we know that high uptake of COVID-19 vaccines requires adequate supply, meeting sufficient demand, and mediated by access, equity, and vaccine confidence. I know the last several weeks have been incredibly frustrating from a supply perspective. Many jurisdictions have had demand far outweighing supply. I am hopeful that, and I expect we'll be in this, we'll still have more demand than supply for the next several weeks, but I'm hoping over, by the end of March, early April, we'll have a better balance, and that individuals' eligibility will expand and individuals will be able to find vaccine easier. In the meantime, we also have to be prepared for the moment when demand is going to go down. The people who want to get vaccinated are getting vaccinated as early as possible. And there is a large population that is still hesitant to get these vaccines. And so we really have to be working now to support vaccine demand, which is going to be an issue after demand decreases and supply increases. Next slide. So in closing, the new vaccine programs bring vaccine to locations people trust. As supply increases, we anticipate seeing vaccine being administered in schools, churches, community centers, and in healthcare providers' offices. It's essential that people have access and trust that COVID-19 vaccines are safe and effective. Confidence in the vaccine program is key, including trust in the vaccine, the vaccinator, and the system. And reaching every individual who would benefit from vaccination is an important and ambitious goal, and one that we need to achieve by working together. And I want to thank all of you for partnering with us over the last several months in this vaccine endeavor. But we all know we've come a long way, but there is a lot more work to be done, and we need to get coverage high to support getting back to normal and ending the pandemic. Next slide. And I will close there, and thank you for the opportunity to speak to you today.
Thank you so much, Dr. Cohn and Dr. Ogden, for those extremely informative presentations. Before we move to the Q&A portion of the call, and it's a good one, please take a moment to answer the questions through the poll on your screen now. For those of you who submitted questions in advance of this call, thank you so much. We received so many excellent questions, and we'll try to get to as many as we can today. Dr. Ogden, the first set of questions are for you. The first one is, what information can a healthcare provider or health department share about a positive COVID-19 patient? Does this information change in cases where a patient refuses to disclose information about their health or about exposures?
Thanks, Nora. Well, contact tracing is really key to slowing the spread of COVID-19, and it helps protect us, ourselves, our families, and our communities. All aspects of case investigation, contact tracing, and clinical management must be voluntary, confidential, and culturally appropriate. Efforts to locate and communicate with clients in close contacts must be carried out in a manner that preserves the confidentiality and privacy of everyone involved. This involves never revealing the name of the client to a close contact unless permission's been given, preferably in writing, and not giving confidential information to third parties such as roommates or neighbors or family members. Healthcare providers should emphasize to patients that the information they share with providers or health department staff, such as patient's name, personal and medical information, is confidential. When reaching out to the contacts of someone who has tested positive for COVID-19, health department staff or medical providers will only say that they might have been exposed to COVID-19. CDC has developed a range of guidance documents, training products, communication toolkits, fact sheets, guides, and tools, and resources for contact tracing and communication, including recommendations for clinicians on management of patients with confirmed COVID-19.
Thanks, Dr. Ogden. Another one, when it comes to faith communities, what does CDC recommend regarding attending services or singing in a choir? What can we do to engage faith leaders and generate interest among them to share information with their congregations? And are there key messages we should be sharing with them?
Thanks. First, I want to acknowledge that while many types of gatherings are important for civic and economic well-being, religious worship has particularly profound significance to some communities and individuals, including as a right protected by the First Amendment. For many faith traditions, gathering together for worship is at the heart of what it means to be a community of faith. But as we all are now aware, gatherings present a risk for increased spread of COVID-19 during this public health emergency. CDC does offer general considerations to help communities of faith discern how to best practice their beliefs while keeping their staff and congregations safe. CDC offers suggestions for faith communities to consider and accept or reject or modify consistent with their own faith traditions in the course of preparing to reconvene for in-person gatherings while still working to prevent the spread of COVID. You can see more information in the CDC's guidelines and consideration for communities of faith.
Thank you. And I know Maria's been putting those links in the chat box. So on a related note, are there specific tips or tactics for how faith-based organizations can conduct successful outreach to their elderly population, to those who have multiple illnesses, or those who are homebound?
Yeah, the U.S. Department of Health and Human Services Center for Faith-Based and Neighborhood Partnerships has issued a guide for faith and community leaders on this topic. And there's several suggestions. Some of the ones highlighted are the importance of supporting local outreach and educational efforts, encouraging prevention practices and obtaining the vaccine, sharing information about how to get vaccinated in your local community through your newsletters, popular social media apps and community announcements. And finally, inviting local health professionals or those affiliated with your community or tradition to talk about the COVID-19 pandemic and address common fears, myths and misconceptions about the virus and vaccines.
Thanks, Dr. Ogden. Okay, shifting gears, will CDC be providing guidance for employee symptom triage and testing for critical infrastructure workers, particularly those in the food and agriculture sector who are currently being vaccinated in some states under Phase 1B?
Thanks again, Nora, for the question. Management in the agriculture industry should conduct worksite assessments to identify COVID-19 risks and infection prevention strategies to protect workers. Worksite guidance for COVID-19 prevention and control should be taken into consideration in employer-furnished shared worker housing, transportation vehicles, and work settings. Workers on farms, ranches, and other production agriculture work sites are considered critical infrastructure workers within the food and agriculture sector. All agriculture work sites should follow as feasible relevant aspects of CDC guidance, including but not limited to this document, CDC's critical infrastructure guidance, and guidance from regulatory bodies such as the FDA or the Food and Drug Administration as needed. Additionally, they should work directly with appropriate state and local public health officials and occupational safety and health professionals. Uniform policies and procedures for screening workers should be developed in consultation with state and local health officials and occupational medicine professionals. The CDC has released interim guidance for agricultural workers based on what is currently known about COVID-19. The CDC and the U.S. Department of Labor will update this guidance as needed and as additional information becomes available. Thanks.
Thank you, Dr. Ogden. Okay, I will ask you in a moment for parting thoughts if you have any, but in the meantime, I'm going to turn to Dr. Cohn and ask this set of questions for you. Starting with this past week, President Biden announced a goal of vaccinating all educators by the end of the month. How is CDC supporting this initiative?
Yes, so this is an exciting development over the last week. As you indicate, the president directed all states, territories, and the District of Columbia to start vaccinating educators. Prior to this, more than 30 states had already taken steps to vaccinate educators, and many more were in the process. But the administration's goal is for every educator, staff, and childcare worker to receive at least one dose or be offered to receive at least one dose of vaccine by the end of March. CDC is working closely with the jurisdictions that have not yet included this population in their prioritization to ensure that they have the support needed to make this change. Additionally, to help jurisdictions accomplish this, the Federal Retail Pharmacy Program is prioritizing vaccinating school staff and childcare workers during the month of March. So in addition to their existing state and local COVID-19 vaccination sites, teachers and staff in pre-K through 12th schools and childcare programs will be able to sign up for an appointment at over 9,000 pharmacy locations that are currently participating in the program. To clarify, the following teachers and staff are eligible. So it's teachers and staff in pre-K through 12th grade schools, child care centers, Head Start and early Head Start programs, licensed child care providers, including center-based and family care providers, classroom aides, bus drivers, janitors, counselors, administration staff, cafeteria workers, and substitute teachers. We're also working to identify best practices for vaccinating this population and identifying barriers to immunization that have been experienced by this particular group of critical workforce. Additional information will continue to be released as we work to ensure all these questions are answered. But this is part of the overall strategy to protect teachers who want to be vaccinated and staff, and help keep or get schools open.
It's exciting. Thank you, Dr. Cohn. And speaking of exciting, late-breaking news, CDC has released today new recommendations for people who have been fully vaccinated. So could you talk a little bit more about why CDC made this update?
Yes, this I don't even know if everybody has seen, but it has been announced this morning and it is available online that CDC issued new recommendations for fully vaccinated people who want to resume the regular activities they may have stopped doing because of COVID. So fully vaccinated people can now visit with other fully vaccinated people indoors without wearing masks or physical distancing, and can visit with unvaccinated people from a single household who are low risk for severe COVID-19 disease indoors without wearing masks or physical distancing. They can also refrain from quarantine and testing following a known exposure if asymptomatic. So to translate that, my parents who are fully vaccinated can now come have dinner in my household, including with my children who are not vaccinated, without wearing a mask. Part of the reason for making this shift is that we're making really good progress with getting vaccines to people prioritized for early vaccination. So more than 30 million people are fully vaccinated. It's important to provide recommendations for what people can do safely while limiting any risk to themselves and others. For now, We still recommend that fully vaccinated people take other COVID precautions, such as wearing a well-fitted mask and staying 6 feet apart from others, if visiting unvaccinated people in groups, or visiting unvaccinated people who are at seriously ill from COVID-19. So for example, my parents cannot or should not go visit friends without socially distancing who may be at high risk who have not been vaccinated, but they can have dinner or visit friends who have been fully vaccinated. And to clarify, all of my parents and their friends are well over age 65. Additionally, people who are fully vaccinated can start spending time in public places like restaurants or gyms, but they should maintain all of those previous precautions, such as wearing a mask and staying 6 feet apart from others. Currently authorized vaccines in the United States are highly effective at protecting vaccinated people against severe COVID-19. And there's also growing evidence to suggest that fully vaccinated people are less likely to have asymptomatic infection and potentially less likely to transmit SARS-CoV-2 compared to unvaccinated individuals. We'll continue to monitor this closely, especially in terms of how long the vaccine protection lasts and how much these vaccines are protecting against emerging variants of SARS-CoV-2. And so we will continue to recommend prevention measures for everyone. And we still want to discourage people from congregating in large crowds. But we're really hopeful that this guidance will allow the over 50% or 40% of 65-year-old and older people who are 65 years of age and older to start socializing with their friends and family. And we're hoping that this expands to more individuals who are prioritized or at increased risk for COVID-19 in the very near future.
Wow, that's great news. I think it's a huge relief to many of us, and a huge incentive for others to become vaccinated. And so our next question is from someone who's had difficulty finding an appointment. How does someone get a COVID-19 vaccine?
Gosh, I wish I could. I wish I could answer this question for everybody. I decided I was going to help my 90-year-old neighbor next door get his COVID-19 vaccine, and this was several weeks ago, but ran into quite a lot of trouble. It was incredibly challenging, so I understand how challenging this can be. Because we knew it was going to be limited at first, states did decide who will be vaccinated first and how they can receive vaccines. So each state is different, even though there are national ACIP recommendations for prioritizations. We do have a couple of new ways to try to support people finding vaccine in their state. And that includes, there's a couple of links we can send out, but we do on the CDC website link to every territory and state to the web page that helps you find vaccine in your jurisdiction. But I think even better, and it depends where you live, but we now have Vaccine Finder, and we'll also put the link into the chat. This is being ramped up, but this is helping individuals and in states find COVID-19 vaccine appointments. So you put in where you live, and it will take you through a couple of questions and try to identify places that do have appointments. I did try this. I try to look for appointments, even though now I don't need any, to see if it's getting easier. And I do feel like it is starting to get easier. There are appointments opening up. So if you have been discouraged because of how challenging it is, and I know it's very highly variable depending on which state you live in, I do encourage you to go back and try. I also encourage you, if you have been vaccinated or you're not yet eligible to get vaccinated, to offer your support to help others in your community try to get vaccine appointments, because it's especially challenging for people who don't have access the internet or just aren't very good at navigating all of this challenging space from a technical perspective.
Absolutely. Thank you, Dr. Cohen. Yeah, bottom line, it sounds like don't give up. And I did see Maria put those links in the chat. Hopefully they're helpful.
Hello? So I can't hear the question, but I'm going to go ahead and keep talking because it sounds like people can hear me. So the next question I'm going to respond to that somebody put in is a question about if a fully vaccinated person is exposed to someone who has COVID-19, what do they need to do? And I answered this a little bit in the prior question, but a fully vaccinated person who's exposed to somebody with suspected or confirmed COVID-19 does not need to quarantine anymore. So, and to remind everyone, the definition of being completely vaccinated is greater than 2 weeks after vaccination, after receiving your final dose. So this is 2 weeks after receiving your second dose for the Moderna or Pfizer vaccine, or 2 weeks after receiving your first dose of Janssen J&J vaccine. So people who do not meet these criteria should continue to follow the current quarantine guidance. And all individuals should continue to watch for symptoms. And if you become symptomatic, then you should quarantine and get tested. We are still, right now, we do not have a time frame around that quarantine. I know that in previous guidance, we did say 3 months, but in this updated quarantine guidance, we are not putting that 3-month period on that, and we will continue to update it as it becomes available. There are some individuals who work in some healthcare settings or in some congregate settings, such as prisons or jails, where that may not apply, and those individuals may still need to be quarantined if they're exposed. But that's really on in a setting by setting case, and in general, individuals can stop quarantining if they've been vaccinated. I'm also going to talk a little bit about whether or not you need to quarantine upon return from travel. And this is true for both if you tested positive for COVID-19 or if you recovered for COVID-19. And we are still recommending that these individuals do quarantine upon return from travel. This is really to help further spread, to help reduce the risk of further spread of these variants. This is the purpose of that vaccination, the travel recommendations. And this is really may be different in your state, tribal, or local area. But all international air passengers traveling to the US, regardless of vaccination or antibody status, are now required to show a negative COVID-19 test result or documentation of recovery from COVID-19. Those departing from or traveling within the United States are also recommended to get tested before traveling. This requirement for testing does still include if you've been vaccinated. So all travelers, regardless of vaccination status, should get tested 3 to 5 days after travel and stay home and self-quarantine for 7 days after travel, even if their test is negative. Travelers who don't get tested should stay home and self-quarantine for 10 days after travel. This is really challenging guidance, I know, to implement, but I do think that the most we can do to reduce spread from location to location and continue to keep our pods of people small is the best we can do.
Thank you so much, Dr. Cohen. Apologies for those technical problems. But next question is related to how long after someone receives a vaccine are they protected?
Great. As we said earlier, everyone does need to get the full vaccine series. So 2 doses of the Moderna and Pfizer and 1 dose of the Johnson & Johnson Janssen vaccine. And then they're considered fully vaccinated 2 weeks after that. We do have a lot more to learn about how long after somebody, about how long this vaccine lasts. But 2 weeks after your last dose is when you can consider yourself fully protected. We do anticipate that protection is lasting 3 to 6 months, and we are doing many vaccine effectiveness studies to understand how long it will last.
Perfect. Okay. Now I want to take a swig of water. We have a few more questions for you, but these are very important. We want to squeeze them in. Next one is, how can my business or organization or group become a mass vaccination site?
So if your organization is interested in and it's being a mass vaccination site, and remember, a mass vaccination site, it doesn't mean it has to be huge. There's community vaccination sites that, where we can vaccinate a couple of hundred people a day, are just important as large mass clinics. But we recommend you contact your state or local health department. If you're a business that you're directly interested in assisting with vaccine distribution to the FEMA clinics, you can directly engage with FEMA through its National Business Emergency Operations Center. But CDC has also released guidance to assist with jurisdictional planning and implementation of these mass clinics. And it offers different ways to, it offers information about how to plan a clinic, including storage and handling and administration. And so I think as we have more vaccine doses, it's really important that we get vaccine as close to individuals as possible. And so businesses, organizations can all be really important catalysts to increasing vaccination, either by being a site or helping to enroll individuals to go to a more central site. And we will put some links in the chat for that.
Thank you, Dr. Cohen. And speaking of businesses, does CDC recommend that employers be actively involved in the vaccination distribution to their actual employees? Should employers organize events to vaccinate their employees?
So this is also shifting as we start to increase access and we'll have more doses to be able to do some of this work. But businesses and employers do play a key role in protecting their workplace, including making COVID-19 vaccination part of a workplace wellness program. To keep the workplace healthy, businesses can certainly consider offering free on-site COVID-19 vaccination at business locations or connecting with a nearby vaccination site. If you are interested in doing this, you should call your health department in the jurisdiction for guidance. I know for larger businesses that have multiple jurisdictions, this really is an individual jurisdictional approach. The planning process for hosting a workplace COVID-19 vaccination program should include input from management, human resources, employees, and labor representatives as appropriate. And there is a link on workplace vaccination. We really do want businesses and workplaces, even if you can't offer it on site, to help support your workers getting vaccinated. So if there are opportunities to be flexible in human resource policies, such as establishing policies that allow employees to take paid leave to seek COVID vaccination in the community, supporting transportation to offsite vaccination clinics, or letting people leave early or have time off. That's a really great way to support the vaccination efforts. We also suggest using promotional flyers to advertise locations in your workplace. And there are toolkits to help promote vaccination in your community that can be adopted. There's also several being worked on that will be available soon for different types of essential worker populations. But being proud of your employees being vaccinated and having them show a way to demonstrate that they got vaccinated is another really good way to make vaccination infectious instead of the disease.
Thank you. Okay, Dr. Cohn, last question. From someone who has had anaphylaxis several years ago and worried about their risk of having another anaphylactic reaction to the COVID vaccine, should that person plan to get vaccinated in a hospital?
Yes, so this has been, at the very early part of the program, we identified several cases of anaphylaxis among people who received the mRNA vaccines. We've continued to monitor this very closely, and the risk for anaphylaxis after a COVID vaccine is actually starting to come down to be very close to the risk for vaccination for any vaccine, which is 1 in a million. I think it's currently right now somewhere between 2 in 5 or 2 in 8 per million. But given that we are, we're vaccinating millions of people, we do anticipate anaphylaxis will occur in some individuals. So people with a history of anaphylaxis should bring their epinephrine auto-injector to the appointment. Every vaccination site has available at all times healthcare personnel who are trained and qualified to manage anaphylaxis. We recommend that every site have 3 doses of epinephrine available at all times. We also recommend a 30-minute observation period after vaccination for people who have a history of an immediate allergic reaction of any severity to another vaccine or injectable therapy, as well as people with a history of anaphylaxis to any cause. So this individual should be watched for 30 minutes. However, when we look at our anaphylaxis data, it is not entirely clear that it is only people with a history of anaphylaxis who are having anaphylaxis after this. And most individuals do have anaphylaxis within the first 15 minutes. However, the take-home message is you do not need to get vaccinated in a hospital setting if you have a history of anaphylaxis. However, you should get vaccinated in a place. All these sites should have the availability of services to treat anaphylaxis, and you should bring your epinephrine pen and you should wait 30 minutes. If you had a severe allergic reaction to your first dose of mRNA vaccine, then you should talk to your healthcare provider or even an allergist about getting your second dose.
Excellent. Thank you so much, Dr. Ogden and Dr. Cohn, for all of the information that you shared today, and for everyone who submitted a question. Don't forget, the option to submit a question is always here. Please feel free to email us if you would like your question answered by our experts on the next partner call. Thanks everyone so much for joining today. A recording of this posted online will be on CDC's COVID-19 webpage and on YouTube in a few days. And the subscription link to receive future updates and invitations is listed on the slide. Just enter your email and then search for COVID-19 coronavirus partners. Until next time, stay safe and be well.